Healthcare disparities have been an ongoing issue for cancer patients for a long period, but I think it's gaining momentum now, and especially in multiple myeloma for a few reasons. So, as our US demographic keeps changing and the proportion of African Americans, Hispanics, Asians keeps increasing, I mean, we're becoming more and more of a multicultural, multi-ethnic demographic. I think some of these disparities are becoming more and more prominent. Also, because in recent years, there have been tremendous increase in the number of drugs that get approved for any cancer. And if you think about it, our clinical trials are more so representative, about 95%, they are representative of whites. That's traditionally been the population where the drugs are tested in. And then they make it to real world, and now suddenly they're getting used by everybody. So the benefit, the safety, the side effects, all of that has to a large extent never been studied in a lot of those populations where the drugs are getting used. So you can see that there's a discrepancy. And I mentioned that it's important for multiple myeloma more so than some of the other cancers because African Americans have twice the incidence of myeloma as compared to whites. Now, granted, African Americans still make about 20% of the US myeloma population, and about 75% is still whites. But that said, in a disease where more African Americans are diagnosed, the prevalence pool for African Americans is increasing much faster. African Americans are diagnosed at a much younger age than whites. Hispanics are also diagnosed at a much younger age than whites. So it affects a working population, it affects decisions related to insurance, caregiver support, et cetera, et cetera. So it's a very kind of a convoluted but multifactorial, multi-edged kind of an issue. So it has been important, but I think just by sheer numbers, it's being talked about much more now. My focus is on the racial ethnic disparities, which is an area where I've spent now maybe 10, 12 years working on it. And prior to Mayo Clinic, I was at USC in Los Angeles, where actually my work in that area had started primarily when I was in LA. So I'll take this racial ethnic disparities as the example of answering your question about what have been the disparities, what have been those gaps, and how are those gaps being bridged as we move on. So historically, the disparities, racial ethnic disparities for myeloma have spanned um, the biology of the disease because it is different for African Americans as compared to whites. It has spanned access to care. African Americans and Hispanics tend to get access to the right drugs much later, and also the access to certain options like stem cell transplant. There is more recent data for one of the newer treatments called CAR T cell therapy that transplant is given or is the transplant is offered or completed by African Americans and Hispanics much less frequently. With CAR T, we are hearing that African Americans get CAR T at a much, much lower rate as compared to whites. Then there are also disparities about disease presentation. Now, these are things that we may not have very much control on, but African Americans, for example, tend to present with much more disease burden. They present with more kidney dysfunction, more anemia, more need for dialysis, for example. Now, that could obviously be because they are being brought to treatment much later, or it could be a kind of factor associated with just their disease biology or presentation. But that said, we do note that there is higher disease burden noted in African Americans. And then when we come to this access to the right treatment at the right time, for example, there was one publication where we looked at how Hispanics get to one of the cornerstone drugs for myeloma on an average about 3.5 months after their diagnosis, as compared to whites who get access to that same drug much sooner. So Those are the gaps that we have seen. But we have also known that if given the similar or appropriate treatments, African Americans should actually have superior survival to whites. So when we see studies where it is reported, oh, African Americans have the same overall survival as whites, I don't think those studies are showing us the true picture, because if access and treatment is similar, then African Americans should have actually a superior survival to whites because they have less aggressive disease biologically, looking at mutations, risk categories, etc. Now, what is being done in the future is a lot of efforts, I think, which are focused on, for example, accruing or recruiting more African Americans and Hispanics to our clinical trials. That ways, when we know how the drugs work in them, what is the side effect profile, well, when those drugs become available, we'll be able to use it for a true real world population. Similarly, there are tons of efforts in research, in funding that is being applied towards trying to overcome these disparities, to try to see how we can provide access to the right kind of drug, the right kind of treatment to the right patient at the right time. So there are efforts through advocacy, there are efforts through foundations, there are efforts through NCI, through FDA and AACR. So for example, FDA has recently said that they would like to see a plan from every clinical trial of how they're going to recruit minorities, racial ethnic minorities to clinical trials. So I think a lot of these efforts are going on. The very fact that we have education spotlight sessions at large conferences like ASCO, ASH, etc., that is also a step in the right direction. We're at least bringing enough focus to this problem, but hopefully, with the small things that we are doing, the small changes that we are making, will be heading towards the right direction, and hopefully, some of these disparities can be mitigated.